Middlekauff. Oops. And I've been at UCLA since 1986 when I started my internship here and did my cardiology fellowship here as well. I'm a general cardiologist, and I'm also a member of the Department of Physiology. I teach in the medical school. I'm an assistant dean in the medical school for student affairs. I do research in cannabis and tobacco-related cardiovascular sequelae or complications. And I see patients. I see patients in the CCU and also my general cardiology clinic. And recently I've joined the sports cardiology clinic, which has been great. I always loved sports growing up, and my love for athletics is one of the reasons I went into cardiology. And it's been really fun working with Dr. Shu and Dr. Nasir in clinic, and also Dr. Krishnan, Sri, is beloved to all the fellows and everybody, who's a terrific teacher. And one problem with the cardiology clinic is it's on Friday afternoon, so I haven't gone as much as I would have liked. But it's a very collegial group, and we've met outside of the usual clinic hours to discuss challenging patients that I've seen in my cardiology clinic, my general cardiology clinic. And it's just a really great learning experience. And I think one of the reasons to give this grand rounds is to make sure that the fellows are well aware of this sports cardiology clinic. It's really fun. You'll learn a lot. There's a real sense of camaraderie and teamwork, and it is Friday afternoon. So, all right. So I'm going to talk about the cardiovascular challenges of scuba diving and also return to play. And I'm wondering if anybody knows what SCUBA actually stands for. I have to admit, I looked it up. I'd heard of it before, but hadn't thought about it for a long time.
Self-contained underwater breathing apparatus.
Wow, go girl. Yeah, how'd you know that, Carol?
All right, the treasure trove of useless information in my brain, I could fill a book.
Well, that's pretty awesome. That is true. Maybe that'll be good for Jeopardy for cardiology at some point for the fellows. So the outline of my talk today is I'm going to present a case. I was asked by a patient, am I cleared to scuba dive? Then I'm going to speak about the emergence-specific challenges of scuba diving. And then I'm going to set these challenges on the background of cardiac disease and how that might be particularly challenging. And we'll return to our case, should our patient be allowed to return to play. And then I'll touch on shallow water blackout, which was in the news a few months ago with that synchronized swimmer. I'm not sure if any of you caught that. And there have been other episodes as well. So I'll explain what that is in the pathophysiology. So let's start with the case. And this is a 25-year-old male asking for cardiac clearance to go on a recreational scuba trip. He was asking in June, and his trip was planned in the fall. He has a history of narcolepsy, anxiety, hypertension, and obesity, and hyperlipidemia. And he developed mild myocarditis after the Pfizer booster in January of 2022. And some of you may have been taking care of him. He had chest pain and fevers and myalgias post-vaccine. He'd had mild symptoms after his after his second vaccination. Then after the booster, it was more overt. He even had an Apple Watch and did an EKG, and he didn't have AFib, but he did have ST segment elevation. But with the encouragement of his family, he was finally presented 3 days later to the emergency room. His chest pain was gone by then. So blood pressure 141/82 with a heart rate of 122 in the emergency room. He was pretty fired up. Afebrile, 99% sat on room air. And his first troponin was 3.6. These are the rest of his troponins during his hospitalization. So they continued to go down. And he had some positive inflammatory markers. I think these were in the emergency room or the next day, with a SED rate of 29 and a CRP of 2.8. And this was his first EKG in the emergency room. I don't know, does anybody want to comment on this? Anything that you see, any fellow want to comment on this? I won't pick on anybody, but feel free to volunteer. How do those ST segments look to you? Yeah, they may be a little bit elevated in lead 1 in AVL. And if I imagine it, I can also imagine maybe a little PR depression there compared to the TP intervals, a little ST segment elevation laterally anyway. And I think it's pretty much confined there. Hidden echo, first echo in the emergency room was no normal EF and no pericardial effusion. That was just by the ER personnel. But when he had formal echo, he was found of normal systolic function with possible inferior wall hypokinesis. They weren't sure, not well visualized. Normal diastolic function, and his overall EF was preserved at 56%. And then he had an MRI, and I'll show you that in a second, where he had subtle inferior and inferior lateral wall hypokinesis with mildly reduced left ventricular ejection fraction, 52%. And they found 2 foci of nodular epicardial delayed enhancement along the mid and apical lateral wall, which are consistent with myocarditis. His hospital course was just 1 or 2 nights in the hospital, benign. He was monitored, didn't have any significant ventricular arrhythmias. His blood pressure was controlled. He had his MRI study while in-house. He was walking pretty much asymptomatic and discharged on aspirin, a baby aspirin, metoprolol 25, and lisinopril. And I think he had come in on lisinopril anyway. And here's his MRI. It's kind of hard to see, but the radiologist put these arrows there. So this is his subtle enhancement here, his myocarditis in the lateral wall. So the question posed was, he's coming in a few months later, should we let him dive? And his dive trip would be over 6 months after his episode of myocarditis. So we'll come back to him. But I was thinking in my younger self when I would go scuba diving, and scuba's fun. What could possibly go wrong? But I started looking into it after he presented at clinic, and a whole lot of stuff can actually go wrong with scuba. So there are immersion-specific challenges of scuba. Arrhythmias upon entering the water, just getting in the water can cause arrhythmias. And then during the descent, there's something called immersion pulmonary edema. We'll go through the pathophysiology of that. And then the ascent, where some of the most serious complications occur, and that's arterial gas embolism and decompression sickness. But just being underwater, it's exercise in a hostile environment. So we'll go through all of these potential challenges of scuba. All right, so let's first talk about when we first jump in the water. And to talk about this, it's best to go back to our basic physiology and animal physiology and talk about the dive reflex. And I've been told, since I've shown this picture many times, that this is actually not a seal, as it was in one of my children's books. It's a sea lion. Anyway, seals have this tremendous ability to stay underwater for for an hour, or even longer than an hour, because that's when they're hunting. And so they have a very well-developed thing called the dive reflex. And diving is not just confined to mammals. Diving ducks have this as well. So the idea is on the surface, they have a certain heart rate. There's a heart rate here, and the seal's heart rate happens to be 140 or so. And then he immerses his face in this ice water slurry. And with the cold, when it hits the trigeminal nerve distribution in the face, that triggers this reflex. And there's an immediate bradycardia that occurs. And you can imagine that this is beneficial underwater to kind of slow things down so he can preserve his scarce nutrients, his oxygen being delivered to the heart and other tissues. And so he can stay underwater longer. So there's an immediate bradycardia. And people have this too. I'll show you the mechanism or how this reflex works out. We have this too. And we actually use the dive reflex clinically. When, anybody know in what sort of setting we use the dive reflex? Greg, I think you were on an emergency room TV show, right? Once when you did this or they did this?
Yeah, ER, so terminating SVT.
Yeah.
About it.
Yeah, so in the emergency room, you put somebody's face abruptly in an ice water slurry, and it's much better than carotid sinus massage or Valsalva. It's a marked vagal, elicits high vagal tone immediately and can terminate an SVT that's using the AV node. So with the stimulation of the trigeminal nerve, there's stimulation of these cold receptors and causes stimulation of the cardiac parasympathetic, and you get an immediate bradycardia. When the sea lion or seal or diving duck stays underwater, then they accumulate CO2, and that stimulates the carotid chemoreceptors, and we would too. We also get CO2, and that stimulates the carotid chemoreceptors in the carotid bodies in our neck. And those cause another reflex. Those cause an increase in sympathetic outflow, usually not to the heart though. It's usually vasoconstrictor, so it helps, preserve body heat underwater, for example. But the other thing that stimulation of the carotid chemoreceptors do are tell you to breathe. It's a very strong stimulus to tell you to breathe. And so, we would usually surface and start breathing. Well, with scuba, you don't get any of that stuff, because when you dive in, you may get the bradycardia, but you're breathing comfortably. You're not breath holding. You're not accumulating the CO2 unless something's gone very, very bad. So you just get the bradycardia. So some enterprising physiologists hooked up some scuba divers to heart monitors, to Holter type thing, and recorded heart rates before the dive, just before the dive, during the dive, and then following the dive. And you can see, people are pretty revved up, pretty tachycardic before the dive. I think it's probably pretty exciting. And also there's some physical exertion before the dive, because you've got all this equipment, you're a little bit uncomfortable, you may have your wetsuit on, you may be hot. And then when they dove in, there was this relative bradycardia heart rate decreased. And then post the dive, it was not a huge increase, but it went back up a little bit. Okay. Anyway, so that's the dive reflex. So just entering the water, one can get a parasympathetic surge, but also not uncommonly, that sort of fight or flight reflex is also being stimulated when somebody jumps in the ocean. And so one may also get a sympathetic surge, and you can have both, and both to the heart may be arrhythmogenic. So parasympathetic surges, sympathetic surges upon entering the water. Sympathetic surge may promote vasospasm, which is also arrhythmogenic, of course, with ischemia, and further ischemia may be precipitated by intense exertion under certain conditions, such as swimming in the cold water against current. So all of these things may summate to increase risk for arrhythmia. So that's certainly one potential complication of diving. Then another complication of diving is the during descent, something called immersion pulmonary edema. And immersion pulmonary edema, let's go through the physiology there. So obviously when you're going down, there's increased water pressure on your body, including on your legs. So that increased water pressure compresses the veins in your legs and causes an immediate, it immediately propels the blood, which may be half a liter of blood stored in the veins in the legs, back to the thorax. So there's a surge of venous return to the right heart. And this is accompanied by a arterial constriction as well. So there's some compression of the arteries, although probably not much from just the water pressure. But there's also the cold vasoconstriction that's supplemented by that sympathetic surge. So there's vasoconstriction to maintain heat. And so that will increase afterload as well. So we have increased preload and afterload as we're going down. And this increased venous return can then cause trauma to the very delicate pulmonary vasculature, the pulmonary capillaries. So we'll have an abrupt increase in pulmonary pressure and pulmonary capillary pressure, and may get capillary trauma as from being immersed in underwater. And then The other thing that's compounding the problem is not only are the veins and arteries constricted, but the pulmonary lymphatics are constricted as well, largely due to compression from the water pressure. And so the lymphatics are less capable of sweeping all that increased interstitial edema from the higher pulmonary pressures, and then somebody can go into pulmonary edema. And I've seen this exactly one time in the CCU where we had somebody who had been diving off Catalina. It was a woman who was brought in with the diagnosis of immersion pulmonary edema. So it's not particularly common, but it is a nuisance. So it can happen to young people, but more common in the older folks that are diving. And it occurs not, upon jumping in the water, but soon after, after 20 or 30 minutes of immersion is enough time for this pulmonary edema to develop. And the symptoms and signs are just like any other pulmonary edema. Patient will present with coughing, shortness of breath, frothy pink sputum, even hemoptysis. Risk factors seem to be older age, so greater than 50, women more than men, interestingly, and a background of hypertension. And maybe that's because of the accompanying diastolic dysfunction that may occur with hypertension, which the heart is less able to sort of accommodate that increased fluid. So a history of hypertension is a risk factor. Interestingly, scuba divers, anybody who scuba dives know that you're told to hydrate, hydrate, hydrate. Don't be dehydrated, because that can predispose to the bends. But overhydration is a risk factor for this immersion pulmonary edema, and it's easy to understand why. If you increase your intravascular volume, you're going to have more volume going back to the lungs. Cold water may be another risk factor. Maybe that further increases the vasoconstriction and venoconstriction as you're trying to maintain heat. More blood volume is channeled centrally as opposed to the periphery when you're in cold water. So again, people diving off California are particularly at risk. Endurance athletes may be at greater risk, and a potential mechanism there is that endurance athletes, runners, swimmers, bicyclists have increased blood volume to begin with, just for their endurance sports. So again, may have a greater risk, greater predisposition to developing this immersion pulmonary edema. But of course, usually endurance athletes have better diastolic function. So maybe a couple hits there. So again, left ventricular hypertrophy is a risk factor, the diastolic dysfunction, and then just underlying cardiac disease can predispose you to not be able to handle this big venous surge. Okay, in the differential diagnosis, not everybody who comes up in pulmonary edema has had immersion pulmonary edema. There could be other problems. They could have had aspirated some salt water. They could be having an asthma attack, or it could just be, cardiogenic pulmonary edema because of their underlying heart disease, or they may have developed ischemia, etc. Well, what do you do about it? Just like any other patient with pulmonary edema, it's largely supportive, so treat with diuretics, oxygen. If they're hypotensive, beta agonists as needed, and it's usually self-limited, but it may recur. So unless there's something really that one can reverse, that I shouldn't have had 10 liters of water before I jumped in or something like that, it may be a recurrent event, and at which case people may be counseled that it may recur and perhaps they shouldn't dive again. Okay, so that's the jumping in and the descent part. Well, how about the ascent part? And that's where probably the worst complications, or some of the worst complications, come in. This arterial gas embolism we'll talk about first. So when you're underwater, you're at depth, you're breathing pressurized air, and your alveoli are nicely inflated, normally inflated. If you hold your breath as you ascend, those nicely inflated alveoli will continue to grow. If you remember, anytime you've maybe packed some food to go with you skiing, going up to elevation, and you had a potato chip bag that was fine at sea level, and then you get up to the mountains and the bag is very puffy, it's taut, or anybody who's flown or gone to altitude knows that with their toiletries, for example, things become overinflated and expanded. So that's what happens to the alveoli. Well, if you continue to hold your breath, then these alveoli will pop, and the air can go two places. One place it can go is into the capillaries, the pulmonary capillaries. And of course, the capillaries drain into the pulmonary veins, which then go back to the left atrium, which then goes to the left ventricle and out through the aortic valve, and can cause a stroke. So one can get an air embolism and have present with a stroke, or also bad luck, it could end up going to a coronary and cause an MI. The bubbles, the microbubbles, may coalesce and cause some of these complications, but the bubbles seem to be well tolerated in blood supply to other tissues. So it's really an MI or a stroke that patients present with this air gas embolism. The other place that I don't think I mentioned the second place. So the other place, so when these alveoli pop, in addition to going into the capillaries, can just go into the soft tissue, into the mediastinum. So one can then develop a pneumothorax, because as one ascends, the air will continue to ascend in a confined space and compress the lungs. And so somebody can have a pneumothorax, even a tension pneumothorax. They may develop mediastinal emphysema and subcutaneous emphysema as well. And the symptoms are not subtle, and they occur upon surfacing, because it's caused by this lack of breathing, lack of exhaling when one ascends. So when you get to the top, you've got your sequelae, and that the diver may present with a loss of consciousness, a cardiac arrest, stroke, chest pain, etc. Before we talk about treatment, I want to talk about the other complication of ascent, and that's the one that's everybody knows as decompression sickness, or the bends. So that's the other complication for when we resurface. And the other name for decompression sickness or the bends is caisson disease. And this was coined, I think, when the Brooklyn Bridge was built. And caissons are those water pylons that are deep. And divers would go down and spend a lot of time underwater securing the caissons for the Brooklyn Bridge. And I think 15% of them presented with the bends, with this decompression illness, and that's where it got its other name, caisson disease. So it's caused by nitrogen being dissolved in tissues when one's breathing pressurized air, that then, as one ascends, this nitrogen undissolves, it becomes bubbles, and then the bubbles cause complications. So it's when bubbles out, the nitrogen bubbles out as we ascend. And it happens if somebody ascends too quickly, or if one has been underwater for too long. And there's usually built-in or required safety stops at about 10 feet below the surface, so the nitrogen can be released. You just hang out there for 5 minutes or so. And if somebody, for whatever reason, doesn't do their safety stop, they're at increased risk for developing this decompression sickness. It's not common. It's 3 cases per 10,000 dives, so it's not common. There are things that one can do or avoid doing to avoid this complication. People that do deeper dives will absorb more nitrogen. So the deeper one is, and for the longer period of time, you're going to get more nitrogen dissolved in the tissues, and so it would be at greater risk for developing the bends. And if one does repeated dives, the nitrogen will accumulate, especially if one doesn't respect the recommended time or interval between dives. So if you do lots of long, deep dives with a short interval between them, one's at increased risk for developing the bends. So those are sort of the dive details that predispose somebody to this. And then, who gets them? Men more than women. Maybe, I won't speculate why that is, but men more than women. older folks, maybe because of different metabolism of the nitrogen, and obesity is a risk factor as well. And then people with right to left shunts, and we'll go through the pathophysiology of that in a moment, or increased risk for neurologic decompression sickness, which is terrible. And then, again, if somebody ascends too quickly, doesn't do their safety spot, they're more likely to get the bends. And also, if it's not just the length of time between dives, but if somebody's diving in a remote place and then gets on an airplane and flies home, there's altitude there. And so the nitrogen is more likely to bubble out during that flight. So it's usually recommended to wait at least 24 hours after your last flight to avoid this complication. So again, the nitrogen dissolved in the tissues during the dive becomes bubbles during ascent. And the bubbles can come out in subcutaneous tissues and joints. And the bubbling out in the joints is what led to the nickname the bends, because it causes people to double over. And it's not really clear why bubbles form at joints, but it may have something to do with the mechanics of the rubbing together of at the joints that generate bubbles and larger bubbles and cause a pain. Similarly, it's not clear why it happens in subcutaneous tissues. Some of the nitrogen that bubbles out will enter veins. It doesn't enter arteries. The nitrogen doesn't enter arteries because the arteries are under greater pressure. So they can stave off these nitrogen bubbles, but nitrogen may enter the venous system. And so if you've, just a little bit of nitrogen in your venous system, that can be cleared at the pulmonary capillaries and you may never know. But if you have a fair amount of these microbubbles, these nitrogen bubbles coming through the pulmonary vasculature, that can cause mechanical disruption of those capillaries. It can disrupt the endothelium of the capillaries and lead to generation of blood clots in the venous system. Activation of platelets and coagulation cascade can be activated, and the endothelium is damaged, so there'll be increased leak of fluids in the interstitial space, and one can become hemoconcentrated if you lose a fair amount of fluid and a hypotensive. And then this can also trigger an inflammatory response. So it depends on the burden of the nitrogen that's sort of bubbling out there. And the symptoms are wide. It's not uncommon actually after diving to get a headache from that sort of mass squeeze, but a headache that's unexplained or out of proportion fatigue. Fatigue is not uncommon after scuba, but either of these can be manifestations of the bends or pain. Pain is a typical thing, and it's often in joints. The skin manifestations too are very prevalent. Get this livido reticularis rash, which is very characteristic of the decompression sickness. And also patients may complain of, it feels like ants crawling, often around their necks, etc. Kind of or a pruritus feeling or a burning feeling in their skin. Again, there's the musculoskeletal manifestations that we're all familiar with. And then the neurological manifestations are the most concerning, because this usually means that there's been a right to left shunting of the air bubbles or the nitrogen bubbles, and those have could be spinal arteries or the central nervous system. And divers can present with numbness, tingling, altered behavior. They may be dizzy, weak, have tremors, be unsteady or staggering, maybe paralyzed, and have urinary hesitancy, even bowel incontinence. They wreak havoc on the pulmonary vasculature. Divers can cough up blood, have the frothy sputum, and may develop shock. So there's quite a spectrum of how ill one is with the decompression sickness. And this usually presents, I should say, several hours after the dive, whereas the air embolism is immediate. This can be up to 24 hours later. Most is earlier than that, but it can be up to 24 hours later. Okay, well, how about this right to left shunting, the PFO? A risk of decompression sickness is 2-fold greater in divers with a PFO versus divers without, and a neurological decompression sickness is 4-fold greater, because you got to figure you got something in the artery. So the venous blood somehow had to get into the arterial system, so more common. But again, thank goodness, this neurological decompression sickness is rare, 4.7 per 10,000 dives, so not a common sequelae. Divers, so the prevalence of right to left shunt, including a PFO in divers with neurological symptoms, is 44% versus 14% in those without an identified right to left shunt. So again, right to left shunt is a huge risk factor for this rare event. And the larger the shunt, the greater the risk. So, knowing that, and knowing that this is such a terrible thing, is routine screening for a PFO recommended before diving? And the answer is no. These things, PFOs are so common, right? They're in 1 of 4 of us. So we don't do, it's the medical and diving community do not recommend screening for a PFO. And the idea is that the risk of a decompression sickness is low, even if a PFO is present, because these are very, very common. It is recommended that one screen for a PFO if somebody has a serious decompression sickness event, such as neurological sequelae or even the cutaneous symptoms, but not the mild stuff, not the headache or the fatigue, which may be a little more squishy. And then even if you do detect a PFO after a decompression sickness episode, it doesn't confirm that it caused it. It's kind of like after those idiopathic strokes in young folks, it's not 100% that that's the cause, but makes it super likely, doesn't it? But again, if somebody says, I want to go diving, I know I have a PFO, should it be closed? Not unless somebody's had an event is it discussed that these should be prophylactically closed. But if somebody does have a decompression sickness and incident, and they are diagnosed with a PFO, then it's shared decision making. There are options. They have options. One is to just stop diving. If you stop diving, you won't have the sequelae, or to choose more, conservative dive profiles. Maybe just do 1 dive a day, or a more shallow dive, or a greater interval between dives. Or one can choose to close the PFO. And we've got expertise here with Dr. Tovas and his team to close those with very, very low risk. But again, closure does not ensure that the decompression sickness will not occur again. So probably doing this and then diving more conservatively would be a wise way to go. How does one treat the acute decompression illness or sickness? 100% oxygen, and most dive boats have this, dive facilities have this, and then get somebody to a hyperbaric chamber as soon as possible, where one will get the 100% oxygen and be repressurized. So putting those nitrogen bubbles back into, getting rid of the bubbles, and then letting them dissipate, the nitrogen dissipate off through the lungs. So this is a hyperbaric chamber from about 60 years ago. This is in Australia, and this was used for pearl divers. And it is odd to me that pearl divers who do not breathe compressed air do get the bends, but apparently they do enough repetitive dives that it is a risk. So this was how it was 60 years ago. And this is the hyperbaric chamber here at UCLA. And earlier this week, I went to visit the hyperbaric chamber, which is right here in the 200 building. I don't know if anybody's been to it, but it's really cool. It's on the B2 level of the 200 building, and it's run by pulmonary and vascular surgery. And here's some pictures from the UCLA Hyperbaric Medicine website, but it's really cool in there. So we have 2 chambers, and they both look like this. They look like big white buses. There's one here, and then there's one along this wall here. This one here is for kind of beds or ICU level or sick patients. And they can take 3 drips, and they can take somebody on a ventilator. So they were explaining to me when I was touring it that this may be used for somebody with an air embolism, CNS embolism, after surgery, for example. And they put somebody in there and with a nurse and can help dissolve the air embolus. And then other people go in most commonly for wound healing. So for patients with diabetes who have a non-healing wound, or for radiation wounds after chemotherapy. And you go in these tubes. So this seats many people. It's almost like a bus. And the chambers are pressurized to about 45 feet. And then but they're not filled with air. Because if you fill the whole thing with air, that would be like making a big bomb. So they just, these hoods that are sealed around the patient's neck are filled with 100% oxygen, because it's regular air in the ambient place. And several people may sit there. They sit there for 30 minutes and then have a 10-minute break where they put in regular air and then back to 100% oxygen. It may take an hour and a half or 2 hours in this compressurized chamber. And there's a technician in there. And you can read books, but you can't bring in your cell phone, no electronics, because again, any spark could lead to a fire. And then here's the control panel, and everything's done manually, where they dial in the pressure. They slowly compressurize the patient, the tube, the chamber, and patients have to be able to clear their ears as they do it. And then they decompressurize them and at the end. And there have to be 2 techs at all time in case one passes out. So it's a lot of safety, backup safety mechanisms built in. Any questions about that? I thought it was the coolest thing. They have an escape chamber if something goes wrong, you have to get somebody out quickly. The whole thing is really neat. Okay, so let's talk about the cardiovascular risk of SCUBA in perspective, because as I was doing this, preparing for this talk, I was really freaking myself out. Overall, SCUBA is super safe. 108 deaths per 1 million recreational dives. Excluding these SCUBA-specific issues, cardiac disease is the #1 cause of death. And you think about who dives. Well, a lot of young people dive, maybe, but also the people that dive are often older. They're older, prior smokers, overweight. It's typical American, going on vacation, going to Hawaii, wanting to dive. So with a lot of cardiac risk factors. So a lot of SCUBA certifying organizations require pre-participation questionnaires. And if you think about it, there's a lot of physical and emotional demands of this underwater exercise. It is in many ways a hostile environment. There are currents that may or may not be anticipated, and you have to kick pretty hard sometimes to get back to the boat, and can be pretty demanding. There's temperature issues when you're on land with this, or on the boat, you're with this heavy equipment, you're hot, and you've got this wetsuit on, and then you get in and it's cold. So there's some fluctuations in temperature, but it's largely cold underwater, obviously. You may lose your visibility, which can be stressful. There's a lot of equipment to deal with. People may be anxious, and especially inexperienced may make everything worse and more anxiety provoking. So a lot of things that you really have to be well suited both emotionally and physically to go scuba diving. There are certain disqualifying cardiac disorders so you shouldn't dive. Untreated symptomatic coronary disease, heart failure, dilated, obstructive, or stress-induced cardiomyopathy, pulmonary hypertension, long QT or other arrhythmia-inducing channelopathies, or paroxysmal arrhythmias that cause loss of consciousness, because loss of consciousness underwater can be lethal. Somebody who can't exercise well, moderate to severe valvular disease, complex congenital heart disease, that's a no-brainer, but even ASDs because of this risk of the right to left shunt and the air embolism. And then the implanted cardiac defibrillator is a contraindication. So there are big 3 that one screens one's patients for: being inadequately treated coronary disease, cardiomyopathy, and arrhythmias. So, I think we're all pretty darn good at screening for and treating coronary disease. So anybody with, I should just say cardiac disease, mostly coronary disease, causes 20 to 30% of all the deaths during SCUBA. So you want to screen your older patients, and you're going to be more aggressive about screening than you would somebody who's, just going to start a running program, for example. I mean, if something bad happens and they're underwater in Tahiti, or, they're going to have a problem. So anybody greater, it's recommended anybody greater than 40 or 45 years with risk factors should have screening. If they have known coronary disease, or clearly if they have chest pain, should then undergo testing. So have an echo and a maximum stress test. If they don't have inducible ischemia or arrhythmias, EF is good. And then there's a little controversy about what counts as a good stress test. Most of the diving agencies say 13 minutes. That's a lot of exercise. That's somebody who's really in good shape. That's like 12 minutes on a Bruce protocol or something like that. That's hard. But most of the diving that one does, like in Hawaii or many places, recreational diving may be easier, more tame than that. So there's a little controversy about what we should demand. But again, one goes through all the testing. If there's no inducible ischemia or symptoms, good EF, safe to dive. If they need revascularization, then reassess after 3 months, or if the EF is low. If they have residual ischemia after their revascularization, or if their EF is low, then you may want to recommend against diving. Cardiomyopathy. In general, people with dilated cardiomyopathy, hypertrophic cardiomyopathy, SCUBA, valvular, diastolic dysfunction, it's really recommended to be conservative and recommend against diving. Again, because of all the unknowns. Symptoms may be unpredictable underwater. There may be arrhythmias that wouldn't have happened otherwise because of all this autonomic changes. There's risk to others, including the dive buddy. Everybody dives in a pair. And there's not access to healthcare in most of these places. You're out in a boat with somebody living the good life, and it just may not be, it's just a different thing. So people with any of these cardiomyopathies should undergo testing. And then there's that shared decision-making thing. I think in general, most of us would advise against diving, but you want to spill it out for them. And, the recommended, this is from from sports medicine, as well as, from the AHA, a patient-centered approach is reasonable, but I'd probably in most of these settings discourage it. Then the final, underlying pathology, the long QT. This is a setup to trigger an arrhythmia for somebody with long QT. So again, conservative approach, but even AFib or anything that causes loss of consciousness, that's fatal underwater. If you faint underwater and you aspirate salt water, or you lose your regulator and your buddy isn't nearby, you're going to drown. So it's really advised against. Absolute contraindications are defibrillator, or at least serious shared decision-making. Defibrillator, and you think, well, a defibrillator, that'll save you. But again, during that time when you're unconscious and the defibrillator is going off, you're aspirating salt water and you're drowning. So probably not a good idea. Absolute contraindication. Anticoagulation can even be a contraindication, or at least it should be a serious discussion, because if those microbubbles cause mechanical injury to pulmonary vessels or to any capillaries, and you're on an anticoagulant, you're more likely for more serious sequelae there because of damage to the vasculature. Permanent pacemakers are okay if they're certified to function at depth. And here's the thing. So again, this algorithm does for long QT, again, shared decision making, but including the dive buddy is important, since they may be picking up the pieces there. If somebody has symptomatic arrhythmias, even benign SVTs, those should be treated before somebody's allowed to dive, because fainting underwater can be lethal, whereas other places, not a big deal. So back to our patient, just for the last few minutes that we have, our 25-year-old patient with myocarditis related to the COVID vaccine 6 months ago. Any thoughts about what to do with him? He wants to go diving. From experience, this isn't a particularly chatty group. I'll give you guys a minute. Anybody want to volunteer what they would do? Well, what I did, we did repeat testing. So ZKG looked great. And instead of getting another echo, which we could have done, we just went straight to the cardiac MRI. And this is actually at 3 months to see how he was doing. And all of the subtle changes that were consistent with the myocarditis had resolved even by 3 months. He had a pretty light case. His ejection fraction was back up to 60%. So when he approached me, I thought, yeah, he can go diving. And there's some formal recommendations what to do with people who have had myocarditis from COVID, but also the recommendation for the vaccine-associated myocarditis is the same. And that is, people with a myocarditis that results in hospitalization or abnormal testing, abnormal results on testing, should have the MRI. And if they're diagnosed with the myocarditis, then exercise abstinence for 3 to 6 months. And that's what we did. And he's fully recovered, but will never have another COVID vaccine, I don't think. But is doing well and did go diving without sequelae. There are recommendations for what to do with COVID and diving. Whoops, sorry, but they're really not that helpful because they mostly focus on all the pulmonary consequences. And I just wanted to quickly talk about shallow water blackouts because I think probably some of you were aware of the shallow water blackout, that synchronized swimmer that had that, and would she be allowed to compete in the international competition. So when we go underwater without scuba now, and we dive, our oxygen falls, and this isn't going to be a surprise to anybody, and the CO2 increases. And when the CO2 gets to a certain threshold, that stimulates those arterial chemoreceptors in the carotid body and also centrally, and tell you to breathe. So it's a CO2 that says breathe, breathe, breathe. And then you start breathing and your oxygen goes up and you don't pass out. So that's the normal response. But people that are synchronized swimmers or Navy SEALs do this. And if you want to see anything terrifying, Google shallow water blackouts and then Navy SEALs. There's some terrible footage. These guys, they save each other because they do this routinely. So what these people do to be able to stay underwater longer is they hyperventilate before they go underwater. Okay, when you hyperventilate, that doesn't change your oxygen level at all. So your oxygen level stays the same. What they are doing is blowing off their CO2. This is on the surface before they go underwater. So now their CO2 is very low. Then they jump in and stay underwater a really long time. Their oxygen falls to nothing, but they don't have any urge to breathe. So they're underwater feeling okay. And they don't have any urge to breathe, but they don't have enough oxygen to keep them awake, and they pass out. And once you pass out underwater, then you're breathing water and you're drowning. And so in these situations, people have to be alert and dive in and save them and bring to the surface. But it looks awful because they inevitably have aspirated some water and are, with serious sequelae. So again, this hyperventilation before is getting rid of our safety mechanism that tells us to surface and breathe again. And that's the mechanism for the shallow water blackouts. All right, there's FAM, and thank you. I'm happy to take any questions, and thank you guys for coming today.
That was fascinating, Holly. Thank you so much.
It was fun to do. And again, I just have to tell you how much fun it is to work with Dr. Shu, who has a question. So I'll try to answer that. Papa Shu's new dad.
Thanks so much, Holly. And fantastic lecture. That was really terrific. Learned a lot. And so glad to have you join us in the sports cardiology program. Really benefit from your energy that you brought to the program. Just one thing I wanted to mention too, with the emergent pulmonary edema too, as you covered, and I think that's especially really important for the fellows, something to think about, not only in divers, but as you mentioned, just swimmers, but also we see this in triathletes. So I think the incidence is thought to be about 1 to 2% of triathletes experience this. Something to think about when you have a triathlete who is now talking about some dyspnea during their swims or shortly after their swims, and appropriate counseling.
That's interesting. I was wondering why.
But another population to think about. What's that?
I was wondering why it doesn't happen to those people over in the hyperbaric chamber. Because a lot of them must, they're diabetics, they're older, they've got all the risk factors, diastolic dysfunction, I'm sure probably a lot with systolic dysfunction, and they're being pressurized to 45 feet. Why don't we see it more or ever from those folks? It's kind of a weird thing.
Good question.
Maybe, you know, they are sitting, they're not horizontal. So
And I
there's
don't
some,
know, is it some internal pressure?
I'm
Yeah,
sorry.
and maybe there's increased pressure in their lungs, like kind of in the other side of the alveoli, so it's balanced.
I don't think so, because they're,
Potentially, I don't know, but yeah.
yeah, they're pressured at 45 everywhere.
They're
So-
probably
yeah.
not getting the vasoconstriction from increased CO2 though in the hyperbaric chamber because they're breathing oxygen, correct?
They're breathing oxygen, but you know, we don't have CO2 when we're diving either. It's nitrogen. But I think you're onto something,
Yeah,
buddy.
you're right.
You're onto something, buddy, because I think the temperature may be a big factor. You know,
Sure.
when you know that's causing the vasoconstriction and venoconstriction, trying to, you know, increase central blood flow and away from the periphery. And that maybe the temperature is a bigger factor than we really recognize, because it seems to me we should be seeing it if it's
Right.
just pressure.
Thank you, Holly, so much. This was awesome. And although you make me not want to go diving anymore, but
No, that was
you
what
know, I was reading something about the free divers, you know, who don't breathe oxygen, just go down, and the reflex, the diving reflex, their heart rates go down to 6 a minute if they go to really big depths, like 100 meters or something. Those the best of. They did testing on them. So we have the same reflex as whales and seals. We just don't, you know,
Yeah.
don't do it.
Yeah, but you can use it. You can use it, and it's very effective in the emergency room with somebody with an SVT. You make that ice water fluoride, put their face in it, and it's very potent. It's just very unpleasant, but that will terminate somebody's SVT for sure. For because it's a very potent reflex in humans, as you're pointing out. But yeah, we usually don't use it. Yeah, it's fun. You know, the sports medicine is fun. I can't encourage you guys enough to reach out to Dr. Nasir and Dr. Shu to come to clinic and join Krishnan, and I think Deepak came too, or it was right? Dr. Ravi, you came. So anyway, so some fellows have come, and it's just really fun. It's really collegial. The patients are great, and you learn something. It's always fun to learn something new. Yeah, so Deepak's going to keep coming. Again, if we could just get it not on a Friday afternoon, I'll put in a plug for that. All right, thanks everybody for coming. Really fun to be with you.
Thanks again, Holly. Fantastic talk.
Thank you.